About 5% of the content domain will be on mental and behavioral health issues on your exam. All right, so let's look at attention deficit hyperactivity disorder. At least for me, I probably have this morning, and let's see if I can pay attention. So, persistent and pervasive core symptoms: inattention, hyperactivity, and impulsivity. Obviously, oftentimes all three of these components are identified, but there are different DSM criteria that we'll be looking at for this. The symptoms affect not only cognitive and academic function, but have a significant impact on behavioral and emotional issues, and especially on social functioning. Many of these children are bullied, picked on, labeled as not being successful, and really have some significant struggles. And because of that, there's a lot of comorbidities. So whenever you are evaluating a child with ADHD or with ADD, be sure to look for existing comorbidities, especially anxiety, and as they grow older, especially oppositional defiant disorder. Now, as you're evaluating individuals for ADHD, especially for your boards, it's important to be sure that they are not presenting a child who looks as if they have ADHD, but actually does not, and rather has an underlying disorder. And one of the more common ones is Fragile X syndrome. And these individuals have a nucleotide repeat disorder where the nucleotides are repeated far more than they should be. Specific facial features to keep in mind, sort of typically described as very coarse, kind of a broad forehead, large ears. Oftentimes they will have cardiac findings that are suggestive to some degree of Marfan syndrome in terms of hyperextensible joints and mitral valve prolapse. Enlarged testicular volume is important to remember, because that's one of the best ways as you read a question to differentiate. So Klinefelter, small testicle; Fragile X, large testicle. Again, they won't tell you the testicles are enlarged. They'll give you a testicular volume. In regards to attention deficit hyperactivity associated with Fragile X, testicular volume will be prepubertal, 4 or 5 milliliters. In regards to Klinefelter, it will be 20, 25 milliliters. So no prepubertal testicular size and pubertal testicular size for your boards. So be on the lookout for an ADHD lookalike, being Fragile X syndrome. Also be on the lookout for alcohol spectrum disorders as being a lookalike for ADHD. Oftentimes the features are similar to Fragile X in terms of the coarse features, but ears are low set, and one of the most characteristic findings is absence or underdevelopment of the philtrum. And these individuals may, at least in part, have their ADD-like behavior due to a disorder associated with maternal fetal alcohol abuse. And then finally, Klinefelter syndrome. Again, in comparison to Fragile X, the testicles will be firm, small testicles, gynecomastia, and these individuals are very, very much uncomfortable in social situations, oftentimes, again, made fun of, and the like. And so the body habitus looks a little bit different, obviously, with these. So I think these are the three most common distractors or lookalikes for ADHD that you need to keep in mind: Klinefelter, Fragile X, and fetal alcohol spectrum. Okay, so also some children may appear as if they have ADHD because of sleep issues. So keep in mind sleep apnea. hearing or vision impairment, substance abuse, side effects from meds and thyroid disorders, and absence seizures. So you can have multiple absence seizures every day, appearing as if you are inattentive. So although 99 out of 100 times when you in the real world see a child who you think has ADD, they won't have any of these issues. From a board perspective, these are some of the things that I would suggest you keep in mind. Absence seizures might be one of the seizure disorders that they expect you to know the EEG findings for, and that is 3 per second spikes, very characteristic on EEG. The only other EEG you might see is that associated with infantile spasms and tuberous sclerosis. And that is a very bizarre pattern, no structure at all to the waveforms. So if you see an EEG on your board, it's going to be one of those two, I'm quite sure. So those are some of the things to think about in regards to your differential. In regards to the diagnosis of ADHD, either 6 or 5 symptoms must be present depending upon the age of the individual. These are the symptoms of the inattentive type, and basically it centers around difficulty with attention, not only beginning with attention, but maintaining attention, doesn't seem to listen, always distracted, does not follow through with tasks, etc. Now, this is the predominantly inattentive type, which is making up maybe about 1/3 of all cases. The predominantly hyperactive or impulsive type, again, maybe about 1/4 of cases, with the combined type always in the majority. These symptoms center around increased motor activity, difficulties sitting still, always on the go, talking excessively, difficulty taking turns, not able to cooperate, and the like. And so the DSM-5 criteria are not something that you need to memorize for your boards, but they are something that you need to be familiar with. So as you read a vignette, you can sort through, for example, which particular type they are describing. Other conditions for ADHD that you need to keep in mind, this is the most important right here, and that is that the symptoms have to be present in at least 2 settings. And the reason for that is that many children may look as if they have ADD, when in actuality, those symptoms are a direct response to their environment. So what I mean by that is if a child is growing up in an abusive household where there is domestic violence, obviously they are going to be anxious. That may increase motor activity, that may decrease attention, but they do pretty well in school when they have a more structured environment. So be sure to read the vignette from the perspective that these symptoms are present regardless of the particular area that the child is in, be it school, home, and the like. Also, these symptoms by definition have to occur at least by 11 years of age. And the reason for that is that the onset of quote-unquote ADD-like symptoms for the first time in, say, a 16-year-old is much more likely going to be due to another disorder such as substance abuse. So the importance of relatively early onset of symptoms present in more than one setting is critical to look for as you evaluate these children. And again, as with all these disorders, symptoms should not be better explained by a different disorder. All right, lab evaluation for ADHD is almost always not necessary. These are the things to consider. We've talked about the possibility of sleep apnea, the possibility of underlying and unrecognized hearing or vision disorder. Symptoms that are suggestive of lead intoxication should be investigated, same with thyroid function. Genetic testing, if you suspect Klinefelter's, if you suspect other underlying genetic disorders, Fragile X again, like we've talked about. And unless you are suspicious of petit mal or absent seizures, EEG is not indicated, nor is MRI unless there are specific findings on neurological exam. Okay, so which one of the following represents a potential contraindication to stimulant therapy in a child with ADHD? Prolonged QT, seizure disorder, IBD, diabetes, or autism spectrum disorder. Okay, absolutely. So let's talk a little bit about stimulant therapy, children who have underlying cardiac disease. First, who are we going to treat in the first place? The American Academy of Pediatrics recommendations for treatment of ADHD do differ a little bit depending upon the age of the child. For those who are preschool, first-line treatment is behavioral therapy only. And if those behavioral interventions are indeed not successful, then medication with methylphenidate is recommended. So it's a two-step recommendation for the younger children. For elementary and high school individuals, both medication and counseling is recommended as first-line treatment. So your answer to the next best step in the treatment of these children will depend upon the age of the child in regards to the AAP recommendations. Stimulant medications in general tend to be more efficacious than the other available meds. And both long and short-acting preparations of amphetamine, dextroamphetamine, methylphenidate, lisdexamfetamine. So that's the difference. Preschool, meds only if cognitive and behavioral therapy is unsuccessful. Adolescents and older school-age children, both recommended as first-line treatment. And the evidence for the benefits of behavioral therapy are more robust. In other words, behavioral therapy, unfortunately, is not always successful. And the other reality of it is it's not always available. And sometimes the only available option is medication. Now, what about stimulants and cardiovascular adverse effects, to get back to the question? It is important to perform a comprehensive history and physical exam to detect heart disease. Family history of sudden death, family history of unexplained early MI, for example. Physical exam is very, very important. And, obviously listening for murmurs, listening for clicks. Don't forget that the murmur of hypertrophic cardiomyopathy can kind of slip by us. And that is definitely a murmur that you want to be able to identify in a child prior to stimulant therapy. It sounds very similar to a flow murmur. And that flow murmur we hear all the time in kids. However, with hypertrophic cardiomyopathy, that murmur will increase with Valsalva and increase with standing, whereas an innocent flow murmur decreases with Valsalva and decreases with standing. So an important part of your cardiac evaluation in any child, but certainly in a child who may be at increased risk of complications due to your medical treatment, be sure that a comprehensive medical exam includes an evaluation for any murmur, and be sure to have that child Valsalva and or stand to make sure that that goes away. And one of the easiest things I think to do, say in a 5 or 6-year-old, they're not going to really understand how to Valsalva, but if you put your hand on their stomach, and I'll oftentimes say, make yourself fat and big like Santa Claus, then they'll really, push your hand up, and that's a kind of a quick and easy way to have a younger child Valsalva. But it's really important before you start stimulant therapy. Initiate pharmacotherapy if there's no evidence of heart disease. ECG is not required before initiating stimulant therapy. Expect the heart rate and the blood pressure to change a little bit, and if these minor changes are in some way detrimental to the child, then that should give you pause about treatment as well. Stimulant therapy in children without cardiac disease does not appear to increase the risk for cardiovascular adverse effects, and stimulant therapy is generally not recommended in these particular individuals. So although there remains a black box warning for stimulants in individuals with cardiac disease, that's how you work through the issue as to whether or not, from a vignette standpoint, you would recommend treatment with these meds or not. It's all about cardiac findings and history. All right, other adverse effects of the stimulant meds are relatively common. Probably the most troublesome is rebound. So as the medication wears off, oftentimes these young people will complain of headache and a good bit of irritability. And you'll hear that from parents a lot. I can always tell when the medication wears off, he just gets grumpy and gets irritable, more difficulty with behavioral issues and the like. Also, remember that stimulant meds do not cause tics. They may exacerbate the tics, but they are not a cause of tic disorder. Less common effects: irritability, mood changes, and sometimes worsening of signs and symptoms, which would obviously prompt a change in medication. Okay, what about disruptive behaviors? Which one of the following is often associated with only a conduct disorder rather than both conduct and oppositional defiant disorders? Losing temper, argumentative, refusing to comply with rules, fire-setting behavior, or quick to blame others for their misbehavior. Associated with conduct, but not oppositional. Which one of these five? Right, good. So fire-setting behavior and hypersexual behavior are probably the two most common concerns that differentiate conduct disorder from oppositional defiant disorder. So oppositional defiant disorder typically presents around 8 or 9 years of age, and it's defined by repetitive and persistent is defined by at least 6 months of negative, defiant, disobedient, and hostile behavior, which has a significant negative impact on their social skills, on their academic performance, and the like. It's not the result of a mood or psychotic disorder, which we'll review in a second. And again, in regards to comorbidity, very often associated with both ADHD and or learning disorders. Oppositional defiant disorder, here are the DSM criteria. And again, don't go memorizing these criteria, just be familiar with them. So as you read a vignette, you can pick out some of the key statements that help you differentiate some of these behavioral disorders. Now, conduct disorder, again, manifests sometimes even a little bit earlier than oppositional defiant disorders. Again, very repetitive and persistent. But the key word for conduct versus oppositional will be antisocial behaviors that violate the rights of others. They oftentimes are very physically aggressive or sexually coercive, fire-setting behavior, cruelty to animals, and importantly, lack of remorse or guilt. So although they sound similar, there are several buzzwords for conduct disorder that will help you to identify that that's indeed the problem that is being discussed. Fire setting, cruelty to animals, sexually coercive behavior, and very importantly, lack of remorse or guilt. No matter how bad he is, he just doesn't seem to care, oftentimes from a parent. Individuals with conduct disorders are typically in one of two groups. One is the loner, and this, unfortunately, is sometimes associated with individuals who then become very violent in schools. If you read about some of the individuals who have gone into schools with weapons, oftentimes they have a history of a conduct disorder, and they'll oftentimes be described as he just didn't seem to have any friends. Or there's the socialized group, and these oftentimes are gang members, and they have strong ties with the peer group. They have no relationship with adults. But there's two very distinct patterns of behavior amongst individuals with conduct disorders. Okay, so that's oppositional defiant disorder, conduct disorder, ADHD. Let's look quickly at tic disorders, which are really very common. Both transient and chronic tics can occur in up to a fourth of children during childhood. These are described as sudden, repetitive, intermittent movements and or vocal tics, and they are not easily suppressible or controlled. That's important. That would be a hint in your vignette about a tic. Despite his best efforts, he continues to do so and so. Treatment is typically behavioral intervention and not meds, because again, a lot of these are transient and a lot of these are associated with, for example, anxiety. And if you can help the child with his or her anxiety, oftentimes the tics improve. Always consider in any child who has a tic, are there any secondary possible causes of this? So again, stimulant medications do not cause tics, but they can exacerbate the tics, as can some of the antipsychotics and the anticonvulsants. So keep that in mind. Remember, as was mentioned earlier, tuberous sclerosis can sometimes not only be associated with seizures, but also with tic disorders. Here's the angiofibromas that you saw yesterday in the dermatology lecture. And we've been through this before, but let's remind ourselves which one of the following is associated with the eye finding that is pictured here: hyperlipidemia, diabetes, elevated urinary copper, juvenile idiopathic arthritis, or herpes simplex virus. Okay, good. So that's Wilson's disease, so decreased serum ceruloplasmin, increased urinary copper excretion. Again, as I mentioned in another talk, this can sometimes be a lookalike for substance abuse, because sometimes the behavioral changes due to copper deposition in the central nervous system present around the same time that one might expect the onset of drug abuse in an adolescent. So, Kaiser-Fleischer rings, Wilson's disease, tuberous sclerosis, and how about this? Concurrent infection with which one of the following organisms may in some children exacerbate signs and symptoms of OCD or a tic disorder? Coxsackie, group A strep, MCAT, H. flu, or HSV. Tics associated with which one of these organisms? Okay, good. Group A strep. And this is pediatric autoimmune neuropsychiatric disorder associated with Group A strep. It's controversial, but symptoms of OCD or tic disorders are in a subset of individuals exacerbated by Group A strep. I actually have a good friend whose child has this, and in talking with this friend, it's really quite remarkable that the change in his son. He says, I know when he has strep throat because his tics get much worse, and as does his OCD. So although controversial, I think you will run into patients where this does indeed seem to be very, very common. It usually affects children 3 to puberty, very abrupt onset, and again, temporally related to Group A strep infection with the various neurologic abnormalities listed here. So there are some tic disorders associated with certain underlying diseases that you need to keep in mind for your boards. Now, what about Tourette's syndrome? This is characterized by persistent, which by definition is at least a year, both motor and vocal tics, with absence of any tic-free interval for at least 3 months. These are persistent, occur many times per day, almost every day. The location, the number, and the frequency changes over time. That's by definition. And multiple motor tics and at least one vocal tic must be present, but not necessarily at the same time. And the peak is usually between 10 and 12, onset several years prior to that time. So persistence, many times a day, both vocal and motor, although not necessarily at the same time. The tics may be simple, they may be more complex, and oftentimes with vocalizations, probably the one that's best known is shouting obscenities and profanities. But these individuals are oftentimes very adversely affected, not only personally, but in regards to their social interactions. Comorbidities are very common with Tourette's, and stimulant medications used to treat ADHD, again, I know I've said this before, may unmask but do not cause a tic disorder. And actually, I've seen some children whose tics actually improve with treatment for ADHD because they're anxious, they know they're not doing well, they know they're labeled, they're always in trouble, and that anxiety causes them to have more tics. You better control their ADHD behavior, they become more successful both socially and academically, their anxiety decreases, and actually their tics become less frequent as well. So discontinuation of a stimulant is only recommended if the tic becomes more of a problem than does the reason you're treating it, i.e. the ADHD, and usually that's not going to be necessary. Treatment for Tourette's, it depends upon how severe. It may be just education and counseling, or it may be some of the various medications that are listed here. So as you're reading your vignette, get a sense of how much or how little these particular tics are disrupting the child's ability to perform and to socialize. All right, other mental health disorders that you need to know. As a reminder, be sure to screen for emotional and mental health every year between 11 and 21, like we've talked about before. Screening includes not only the child, but his or her parents or guardians, and a careful screen for the various comorbidities that are listed here. How do you screen? Again, there's not a specific recommendation from the Academy. They're just going to want you to know to screen. And one of the easiest questionnaires is just a 2-item screen, the Patient Health Questionnaire, asking these 2 questions. And here are the scores. And if you have a score of at least 3, then you need to look further into evaluating and perhaps treating this individual. But for your boards, know that you screen every year between 11 and 21 based upon not only the child, but the child's environment and the parental history. Mental health disorders, continuing, psychotic or thought disorders. There are delusional disorders, brief psychotic disorders, and schizophreniform disorders. These definitions are important for you to know because they may describe a patient and then say which one of the following disorders is this patient most likely to have. So based on these criteria, that's how you can sort through. And remember that the characteristic of schizophrenia is the length of the illness and the severity of hallucinations, paranoid behavior, bizarre delusional thinking, and disorganized thinking. And unfortunately, this sometimes first appears late in adolescence, so-called psychotic break. And this is something that you may be tested on, even if they describe a individual who has done pretty well prior to the onset of these symptoms. And this is really one of the more tragic, I think, presentations of the various thought disorders. Then there is also schizoaffective disorder, which by definition includes bipolar episodes or a major depression along with these particular symptoms consistent with schizophrenia. So these various definitions, I think you should know so you can identify the underlying mental health disorder that they're describing. Now, what about mood disorders and mania, hypomania, bipolar disease? So the definition of mania is listed here. So expansive, elevated mood, increased energy, goal-directed activity, although the goal-directed activity is there, accomplishing those goals is unusual because you go from one goal to another goal to another goal. Inflated self-esteem, pressured speech, decreased need for sleep, racing thoughts, and another buzzword, buying sprees, bought a new car, or sexual indiscretions. So lots of poor choices, lots of energy, no need for sleep, high self-esteem. That's an episode of mania. By definition, and this is important because this will help you differentiate mania from hypomania, is that these symptoms have to be present for at least 7 days for the majority of the day. So, which one of the following is associated only with mania rather than with both hypomania and mania? So, specific to mania, which one of these 5? Elevated, expansive, or irritable mood, decreased need for sleep, increased energy, inflated self-esteem, or psychotic features. Which one of these? Okay, great. So all of these can be associated with both mania or hypomania, not psychotic features. So hypomania versus mania. Hypomanic symptoms are very similar to mania, but less severe in terms of intensity. Present for 4 days. Remember, the other was 7 days. And psychosocial functioning in hypomania is either mildly impaired or may actually be improved. If you talk to some patients who have hypomanic episodes, they'll describe those as their most productive. So it doesn't necessarily interfere with functioning, whereas functioning in mania is always impaired. So that's another way to differentiate these two. How long have the symptoms been present, 4 or 7? and how much or how little is functioning impaired. Unlike mania, hypomania does not include psychotic features, whereas mania does. Superpowers, being the Messiah, etc. So there are some buzzwords that will help you sort out what's mania, what's hypomania. How long have they been present? How much or how little functioning is interrupted? Are there or are there not psychotic features? Which brings up the definition of the difference between bipolar 1 and bipolar 2. Bipolar 1 is characterized by episodes of mania and episodes of hypomania and major depression. So all three, mania, hypomania, and major depression. Contrasted to bipolar 2, absence of manic episodes. So depression and hypomania present in both, but mania present in bipolar 1, not bipolar 2. And that's how you can tell the difference during a vignette. And what's cyclothymic disorders? And sometimes it's described as not quite mania, alternating with not quite major depression. In other words, it doesn't meet exactly all the criteria that we have been talking about. So that's mood disorders. Other mental health disorders to keep in mind: anxiety disorder, excessive, prolonged, unrealistic fear that interferes with daily lives. Sort of a step up from anxiety disorder, phobia. The anxiety is intensified to the point where the fear is clearly out of proportion to the actual danger, and the child makes every attempt to avoid the object or avoid the situation. And whereas anxiety, you can, for the most part, function during the day, when a phobia is problematic, that oftentimes significantly disrupts the normal activities of the child, leading sometimes to PTSD, where the child is severely affected for months or even years by re-experiencing a trauma. And again, back to the very first thing we were talking about, all that looks like ADHD is not ADHD. And of course, when a child is anxious, when a child is fearful, they're not going to sit still in school. They're not going to pay attention. They may be irritable. And that's why it's so important to get a detailed history, especially before placing these children on stimulant meds. Now, obsessive compulsive disorder includes rituals and superstitions that are incongruent with age appropriateness. These oftentimes interfere with school, interfere with friendships, and the like. And you should know the difference between obsessions and compulsions. Obsessions are persistent and recurrent thoughts, which are intrusive and involuntary. What if this happens? What am I going to do if? Whereas compulsions are actions and purposeful behaviors in an attempt to stop the obsession. What if my house burns down when I'm in school? Therefore, I must check the stove 4 times in the morning and 5 times at night before I go to bed. So the compulsions are an attempt to decrease the possibility of an obsession, and obviously these can become very problematic for the child or for the teen. And then finally, the definition of major depressive disorder. We've talked about the importance of depression and ruling out depression on a yearly basis, the common association of depression with ADHD, of depression as a component of both bipolar 1 and bipolar 2, and these are the various signs and symptoms associated with depression. And at least if you read these, there's some crossover with substance abuse, which we're going to finish up with in just a couple of minutes. So again, don't memorize them, just be familiar with them so you can recognize them as signs and symptoms are described in a vignette on your boards. Persistent depressive disorder, otherwise known as dysthymia, by definition has to be present for at least 2 years. Treatment options for boards for the general pediatrician. Obviously, therapy, be it individual and family, counseling, psychotherapy, cognitive behavioral therapy, and the like. In regards to meds, I think it's reasonable to know for your boards that SSRIs in general are the first line treatment for this. Fluoxetine, in regards to approval, is the only one that's actually approved for children in depression down to 8 years of age. But again, all of these are utilized oftentimes in the pediatric and certainly in the adolescent population. And depending upon your level of comfort, whether you also become familiar with treating some mood disorders or add an antipsychotic to an individual who's on an SSRI. But I think for your boards, kind of the take-home message is know the SSRIs and know at least how to identify an antipsychotic. And remember that those antipsychotics are associated with weight gain and in some cases galactorrhea. That's a look-alike for a central nervous system tumor that they might try to trip you up on. All right, separation anxiety, typically around 6 months of age, peaks between 9 and 18, lessens by 3 years, and we've all had this probably with our own children as well as with younger children that we know. And the main intervention, so to speak, for your boards is just tell mom and dad to separate quickly. Don't keep coming back and saying goodbye, saying you're going to be okay, because that just starts the process all over again. And transitional objects are really quite helpful, especially around bedtime. School refusal. Bottom line for that is get the child to school. Help to facilitate that with some buy-in from the principal at the school or the school nurse. And these are the children, oftentimes they have some OCD. Something's going to happen to mom when I'm at school, so I need to make sure that I have a sore throat and a stomach ache so I can stay home and make sure that she is okay. These children really struggle. Parents, understandably, really struggle, but for school refusal, these somatic complaints, if at all possible, should not keep the child out. Even if I've had parents say, I'm sorry you don't feel good, so you can stay with the nurse at school, but you got to go to school. And the longer that doesn't occur, the more difficult school refusal gets to be. And this actually has a definition of missing several days of school per week for at least the last 2 weeks. All right, sleep problems. Very quickly, AAP very strongly discourages co-sleeping because of the risk of death from suffocation or entrapment, and has very specific recommendations that you all are well familiar with in terms of SIDS protection. For toddlers and preschoolers, main take-home message, structure and routine, structure and routine, structure and routine. And that structure and routine should not include any screen time or the presence of any screens in the bedroom, especially as the children get older. And then recommendations to solve sleep problems, routine, 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 home bed, and very importantly, to put the child down when awake. As nice as it is to rock your baby to sleep, and I've done that and enjoyed that many times with my own children, it's not the best idea to put them down when they're asleep, but better to put them down when they're awake so they can see you leave the room. And no nocturnal feeds really after 4 to 6 months from a physiologic and a physical standpoint are indicated or necessary. All right, in contrast to night terrors, nightmares are associated with which one of the following? Marked diaphoresis, ability to recall the content of the dream, mydriasis, an unconsolable child, or breath-holding episodes. So nightmares is associated with which one of these five? Good. So ability to recall the content of the dream. Much of these symptoms, or many of these symptoms, are associated with night terrors. So let's look at the difference here. So nightmares, children can recall the nightmare, peaks at 3 to 5 years of age, and they can be reasonably and quickly reassured, and oftentimes have some resolution and some comfort by talking about the nightmare. And again, like many behavioral issues, if these are recurrent, then you might have some concerns about the family environment. Night terrors, in contrast, peak a little bit later. The child appears to be awake but is not, and is unresponsive, inconsolable, diaphoretic, tachycardic, dilated pupils, and has no recollection of the episode. And these can last 5, 10, even 30 minutes, and obviously very distressing for parents because you simply cannot calm the child down. I've had parents say, I know he's looking at me, but he looks like he's looking right through me. His eyes are wide open, and I just can't get him to focus. So a little bit later than nightmares, and again, the buzzwords to help you differentiate between the two are right there. Now, no specific intervention is indicated for either, except, again, if you have concerns about something disruptive in the home, like domestic violence. Confusional arousal, the way I look at this is sort of a night terror that occurs too early. And what I mean by too early is looking at the age group, because this peaks in toddlers, usually right after sleep begins. And oftentimes these individuals will cry out. Again, they are inconsolable. You just can't do anything about it. Again, very worrisome to parents. So a confusional arousal is essentially a quote-unquote night terror at the wrong age, otherwise very similar to one another. The treatment for all of these, again, is reassurance as long as the family situation appears to be stable. Sleepwalking, the child appears to be awake but is not. And again, the treatment is keeping him safe or keeping her safe, getting them back to bed, peaks around this age group as well. And oftentimes, individuals with a history of sleepwalking, for some reason, also have a history of breath-holding spells. So, what are breath-holding spells? There's two kinds. Cyanotic, no, you can't have a cookie. No, you can't have this toy. The child cries, 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 then holds their breath, and then loses consciousness, may have a seizure, may become cyanotic, and very frightening, obviously, to parents. Even more frightening, I think, are pallid breath-holding spells. My son had a pallid breath-holding spell one time when he was flying a kite. He was watching the kite running this way and whapped himself into a tree. I literally heard him hit the tree when I was in the front yard, ran around the back, and he was having a tonic-clonic seizure. So I calmly looked at it and said, this is a pallid breath-holding spell. I was so scared. And I think I almost had a seizure. So, of course, I took him to the pediatrician, who made fun of me and said, you know what that was. They are terrifying. So cry, 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 then hold your breath and maybe pass out, cyanotic. Or hit, painful, quickly hold your breath, and the syncopal episode, again, can be associated with tonic-clonic movements, and some have even documented a brief period of systole. I did not check his pulse, thank goodness, because if that had been present, I would not be here. Colic. All right, we all love colic. 2-week-old infants cry 2 hours a day, more than most parents realizes. This increases up to 3 hours per day by 6 weeks of age and then decreases. So what's colic and what's not? So features of colic, really the cause is still yet to be determined, but the bouts of crying by definition are prolonged, paroxysmal, and refractory, abrupt onset and resolution, high-pitched, unrelated to where the child is, unresponsive to intervention, typically worse in the evening, and again, one of these pediatric things, benign but very difficult to tolerate. It's like the febrile seizure, but it's benign. The syncopal episode, but it's benign. It's hard to bring that to bear with parents. So 3 rules: present for at least 3 hours a day, at least 3 days a week for at least 3 weeks, but not before 3 to 4 weeks of age, not after 3 to 4 months. So if you're reading a vignette that sounds colicky, but it's the wrong age group, for example, then they're giving you a distractor. So there's a lot of distractors for colic. Again, age of onset. Bouts are not daily. Perhaps it's due to the GI symptoms are not due to colic, but a change in feeding patterns. And the differential diagnosis can be long: corneal abrasion, hair tourniquet, anal fistula, GERD, a hernia, otitis, non-accidental trauma, anomalous origin of the coronary artery, SVT, or torsion. So there's a lot of things to think about. So corneal abrasion, again, abrasions are translucent, ulcers are opaque. Hair tourniquet, anal fissure, SVT, just as some examples of what might look like colic and what to keep in mind. This is a long list, but certainly you want to make sure, for example, that there's not an inguinal hernia, or worse yet, a testicular or ovarian torsion. Bless you. Colic intervention, most get better by 3 months. About a third will persist up to 4 months. Reassurance, reassurance, reassurance. We all know about the car rides, the swings, and the rockers. If mom is breastfeeding, and if she can identify perhaps a relationship between intake of a certain food and an increase in colicky symptoms, that's fine. But in the vast majority of cases, I don't think that that's going to be the case. Some might try an hydrolysate formula, and there's little data to support all of these other potential interventions. But for your boards, as you're reading about a colicky baby, be sure that there's no buzzwords to suggest that it's one of these other disorders that can mimic colic. And probably another common one is if colic is intermittent rather than persistent, and the child is described as during the colic bringing his knees up towards the abdomen, they're starting to describe intussusception. So remember, intermittent colicky pain, especially with bloody stools or current jelly stools, is likely going to be intussusception. Another 2 things about intussusception that come to mind. Sometimes it presents not with the classic recurrent intermittent colicky pain, but presents with altered mental status. And the other thing to remember about intussusception is the age group, typically 9 months old to maybe 18 months old. If you see intussusception in a 7-year-old, that is likely due to one of 2 things: lymphadenopathy due to an underlying neoplasm, or HSP because of the GI vasculitis associated with HSP. Discipline, that's pretty quick. From an AAP standpoint, no corporal punishment. That's your answer. For the boards, these are the various types of discipline that the Academy recommends. Natural consequences, as long as it doesn't put the child at any risk. Logical consequences: if you do A, B will happen. Withholding privileges or timeout, most effective up to 6 years of age, with about a minute per year. But no corporal punishment is the answer for your boards. All right, we'll finish up just in a few minutes with a quick overview of substance use disorders. So, signs and symptoms of adolescent substance abuse, again, oftentimes kind of looking like depression, but change in behavior, legal problems, poor school performance, loss of interest in regular activities. That's a huge red flag. Used to love to play soccer and now could care less, misses practice, but still shows up late to home. Withdrawal from longtime peers and peer-related activities. New set of friends, but never brings those friends home. And again, irritability, at times lack of remorse, changes in energy, changes in mood. Know the CAGE questions for alcohol abuse. These are listed here. And know that one positive answer from these 4 equals a positive screen. So the next best step is additional intervention. There's also the CRAFT questions for substance abuse. And know that in regards to responses, more than one response is concerning as well. So the CRAFT questionnaire and the CAGE questionnaire are easy to perform in an office setting. General pediatricians should know about them, and it's likely going to be on your boards. Now, we looked at this before. I just want to, again, include this. This was in the adolescent lecture, but since we're talking about drugs, just as a reminder that the AAP does not endorse home drug testing and advises against involuntary drug testing of adolescents. And if drug testing is performed, the Academy recommends that it is performed with the knowledge of the adolescent. And involuntary testing, here's the exceptions, and at times may be appropriate after an accident or suicide attempt or unexplained seizure, a major change in school performance, and the like. But in general, your answer is no drug testing at home and no drug testing without the adolescent's knowledge, with the specific exceptions that are listed here. And the reason for that is that problem drug use is much more likely to be detected by inquiring about all the things that we've talked about: change in friends, grades, school performance, and the like, rather than simply saying, do you use drugs? Or I'm just going to check your urine to make sure that you don't use drugs. And when parents want you to drug test their child, it's a great opportunity, according to the Academy, not again to jump to drug testing, but to initiate a discussion with the parents to try to get a better idea as to what's causing those parental concerns. So what are you going to do with the results? Why do you want it done? What are we going to do if it's positive? What are we going to do if it's negative? And remember that just because it's negative, it doesn't mean that your child is not using drugs. All right, so let's look at some of the specific drugs and we'll be done. If chronically abused, which one of the following can be detected by urine drug screening for up to a month after the drug was last used? So cocaine, amphetamines, opioids, marijuana, or PCP. Marijuana, great. Okay, so let's talk about that. So how long can you find them? Again, with chronic exposure, by far, marijuana can be detected out as long as a month. All of the other drugs, be it acute or chronic use, it is not much more than 2 or 3 days. And that includes these particular tests. Now remember that these particular drugs make up a basic urine drug screen. More comprehensive urine drug screens can also test for hallucinogens and so-called date rape drugs that we'll talk about in a second. So, substance use disorder, how bad is it? And the severity is specified as a subtype based on the number of criteria from the DSM-5 that are present. Is it mild? Is it moderate? Is it severe? It's considered either mild, therefore substance abuse. Moderate or severe is considered substance dependence, depending upon the number of criteria. And all the criteria are listed here for you. Again, be familiar with them so you can better define whether it is substance dependence or substance abuse. So taking in larger amounts over a period of time, persistent desire or can't stop, lots of time getting the drug and recovering from it, a craving that gets worse, now interfering with responsibilities, continued use despite problems that it's creating. Again, giving up activities that were once important, recurrent use in situations where it's physically hazardous. Again, unfortunately, the most common cause of mortality and morbidity in the adolescent and the younger children as well is unintentional injury. Oftentimes those unintentional injuries are in some degree related to substance use, especially in males. They know it's wrong, they know it's hurting them, they continue to do it, and signs of tolerance and signs of withdrawal are beginning to occur. So these are the criteria that will help you define how serious it is. So compared with cannabis, synthetic cannabinoids have a greater potential for which one of the following adverse effects: impaired coordination, nystagmus, psychosis, hypertension, or injection of the conjunctiva. So synthetic cannabinoids are associated with which one of these much more commonly? Good, absolutely, psychosis. So let's look at that a little bit more carefully. So the signs of ingestion of marijuana are listed here. Conjunctival injection is very common, and it's probably the buzzword on your boards for marijuana use, as well as euphoria and distortion of time. Those are probably going to be the most common. Increased appetite and food cravings, and in chronic use, this unusual that no one can explain phenomena of hyperemesis, which is relieved with hot showers. And that's definitely a buzzword that I've seen on several boards. The adverse effects, so-called anti-motivational syndrome, associated with difficulty concentrating, lots of difficulty with executive functioning, and psychomotor retardation. Now, that compared to the synthetic types, rapid urine drug screens will not detect synthetic cannabinoids. That's important. The effects are very similar to marijuana, with the exception of psychosis. And the psychosis can be very severe and very frightening, certainly to see. And the more serious toxicities in addition to psychosis include seizures and coma, as well as MI and hyperthermia leading to CNS damage. So the synthetic cannabinoids, the buzzwords are psychosis and hyperthermia that you should probably be familiar with for your test. Bath salts, again, very frightening. Psychotic and violent behavior is very common with these, and obviously there's lots of other worrisome signs and symptoms, but they are used for the feelings of euphoria and increased energy and increased sexual desire and sexual drive. But the hallucinations, psychotic and violent behavior can be very severe, leading to personal harm as well as harm to others. Cocaine, the signs of ingestion are listed here. Again, typically used for feelings of pleasure, power, and strength, and increased alertness. The adverse effects, especially that you're going to want for your boards, MI, and because of the vasoconstrictive actions of cocaine, cerebral hemorrhage. So certainly any adolescent or young adult who presents to the ED with an MI, assuming they don't have a structural defect to their heart, may very well have been abusing cocaine, and the vasoconstrictive activities or properties of this can cause significant cardiovascular and significant neurologic complications. Methamphetamine ingestion, again, used for the purposes of euphoria, increased energy, and feelings of pleasure, and increased alertness and confidence. So the signs of ingestion are oftentimes very similar with cocaine and methamphetamine, as well as the bath salts that we looked at. Most common is so-called meth mouth. Terrible dental destruction because of smoking meth. Also nasal congestion and septal injury, not only with methamphetamine, but also with cocaine. You can develop actually a perforation of the nasal septum or a nasal septal hematoma due to the trauma associated with attempts to sniff the particular drug. And again, methamphetamine may be associated not only with hypertension, but with myocardial infarction. But meth mouth is probably the one that you're going to be tested on, or the injury to the nasal septum. Opioids, unfortunately, you are well familiar with this because of the opioid epidemic. Signs of ingestion are listed here. And the adverse effects are numerous, obviously with the most worrisome being respiratory depression leading to death, hypothermia, hypotension, so very opposite of all the other various drugs of abuse that we have been looking at. Withdrawal, you should know for the opioids. The first finding is oftentimes yawning, big buzzword for your boards. Lacrimation, mydriasis, and anxiety, diarrhea, and piloerection. These are very typical descriptions that I think would be likely to appear on your boards. Benzodiazepines, very similar to the opioids in terms of a sense of calm and relaxation and drowsiness. Again, the signs of withdrawal can be similar to the signs of withdrawal from opioids. Probably the buzzword for benzodiazepine is flu-like symptoms, again and vomiting and diarrhea, myalgia, and headaches, but again, very similar. So perhaps yawning for opioids, flu-like symptoms for benzodiazepines for the key words on your vignettes. And adverse effects are listed here. Again, very similar to opioids, especially in regards to concern about respiratory depression. The rave club drugs, or the quote-unquote date rape drugs, because they are colorless, because they are odorless, they can be administered to individuals unbeknownst to them through drinks. They reduce inhibition and importantly for your boards, but unfortunately produce both anterograde and retrograde amnesia, and that's an important buzzword for your boards, that there's just no recall of the specific event. Examples are listed there. Adverse effects, especially for these, buzzword, muscle cramping and bruxism. Again, some of these are going to be seen with a variety of other drugs. These seem to be more consistent with the two types of drugs that we're talking about here. So abuse of which one of the following drugs is most likely to be associated with seizures due to hyponatremia? MDMA, cocaine, methamphetamine, opioids, or marijuana? Think of the rave party. All right, good. So MDMA. So ecstasy, MDMA used for its stimulant effects and its hallucinogenic effects, associated with enhanced sense of well-being, intense feelings of love and affection, and an increased sense of energy. Oftentimes at so-called rave parties, individuals will water overload for a couple of reasons. Ecstasy is associated with hyperthermia. The parties are in closed areas. It's hot. People are very active. It's crowded. And to avoid some of the effects of hyperthermia and sweating, there have been multiple reports of, unbeknownst to the individual, drinking too much water and then presenting with hyponatremic seizures. So water loading on your boards is going to be one of two things, and we've talked about them both. One is this, and the second is the anorexic who is trying to gain weight just prior to the office visit. So remember the association of hyponatremic dehydration and seizures with this particular drug of abuse. Finally, inhalants. Signs of intoxication are listed here. Again, very similar to the reasons behind why other drugs are used. Keep in mind that inhalants are cheap, readily available, and oftentimes abused by middle schoolers as well as those in the first part of high school. Perinasal and perioral rashes. That's a buzzword. The inhalant is soaked on a cloth placed over the mouth and the nose and causes a contact dermatitis. Not only inhalants, but certainly any drug that is inhaled or sniffed may cause a pneumothorax, in this case a tension pneumothorax, where as you can see, the right side of the heart is pushed by a large pneumothorax secondary to inhalant abuse. Hallucinogens, there are a variety of hallucinogens. Again, these are not identified on a routine drug screen, but they can be identified on an expanded drug screen. And here are some of the not only signs of intoxication, but some of the reasons for which hallucinogens are abused. Adverse effects are common, and they are outlined here. Probably the one to look for is flashbacks. That is specific for hallucinogens. Nystagmus is another that is more specific for hallucinogen abuse. And that's sort of the quick and dirty run through substance abuse. Thank you very much.